Okay, everybody, we are going to discuss gait training and assistive devices today. There's a chapter in your textbook, Navigating the Challenges of Ambulating, so please make sure that you have reviewed all of that. Uh, the objective, in many ways, related to uh, this topic has to do with our role as physical therapists. We are the go-to discipline for gait training and assistive devices. And we want to make sure that this is an area that we are very comfortable with. Um, Learning objectives are stated here. We're going to talk about the different gait patterns, uh, when certain assistive devices are indicated and should be used, how to fit assistive devices to our patients. And so we'll begin with the review of normal ambulation. Uh, with the gait cycle, 60% of the time is spent in stance and 40% in swing phases. And as you remember, initial contact to loading response, mid-stance, terminal stance, pre-swing, and then the other leg, initial swing, mid-swing, and terminal swing. Um, we won't get into much depth, much more than this, talking about gait, but all of these concepts will be applied. So we'll begin with weight-bearing status. We've had some discussion of this already in foundations, but there are situations where weight-bearing is restricted. This comes from the referring physician, often an orthopedic surgeon. Non-weight bearing is exactly what it sounds like. There's zero weight through that involved lower extremity, and our role often becomes quite critical, instructing patients and ensuring that absolutely no weight is going through that leg. So this compared to toe touch weight bearing or touchdown weight bearing, uh, this is where I guess one way to describe it is one toe can be used for balance. So there is still virtually no weight going through the involved limb, but the toe can be touching the ground. Sometimes therapists will instruct their patient that no more, enough pressure to break an egg. If an egg were underneath their foot, that would be too much pressure. So toe touch is literally uh, almost non-weight bearing, just touching the toe to the ground. And then partial weight bearing is non-specific. It's not full weight bearing, but if the weight bearing status is nothing more than partial weight bearing, then it becomes synonymous with weight bearing as tolerated. However, under partial weight bearing status, there are at times a percentage that is given. The doctor may indicate 20% or 50% weight bearing, and so in some scenarios, it will actually go to the point of using a bathroom scale to instruct our patient, kind of what 20% means or what 50% feels like. Um, Weight bearing is tolerated is exactly that, usually 50 to 100%, but that will just be whatever the patient feels comfortable with, and is usually a progression as they get more confidence, more strength, and endurance, then they progress to full weight bearing. Again, just to reiterate, typically speaking, physical therapists do not change a weight bearing status that comes from physician orders. That being said, very often physical therapists will make recommendations and provide feedback in terms of how the patient is progressing, which information may be used to adjust the weight bearing status. Very often it is a direct correlation with their healing time frame. So if they've had a fracture and or a surgery to reduce and repair that fracture, the weight bearing status is a function of time. They'll wait a certain number of weeks before they return to the surgeon for example, a post-operative office visit, and if everything has been progressing well and the sufficient amount of healing time has passed, then the surgeon will often upgrade the weight-bearing status. So before we begin gait training, obviously there's a lot of information we want to know. Of course, cognitive status is critical with many situations where we are teaching patients important information. They need to be able to have the ability to follow instructions and remember what has been taught to them. Just like we discussed with transfers, we want to have everything ready before getting a patient up to walk. So we want to have our gait belt on hand and then on the patient, and the assistive device close and adjusted correctly, and have clear communication so the patient knows what is happening. We also want to make sure that we have a plan. We can't always predict exactly what a patient is going to tolerate, but if, for example, we're in our patient's hospital room and our hypothesis or assumption is that they can walk 50 feet, for example, we may want to make sure there's a chair in the hallway just so that if they need a place to rest, we're prepared for that and we can let them sit before, for example, returning to their room. Of course, gait belt with a palm-up grip. We do not ever want to be walking a patient without a gait belt unless they have progressed dramatically and we have ensured that it's not needed. Certainly, the first time we are walking with a patient, a gait belt will absolutely be required. So footwear is something to consider. In some inpatient settings, that can be a challenge, and we may ask patient family members to bring footwear from home. We want to make sure that they're tolerating the ambulation, and vital signs is a great way to assess their blood pressure and heart rate and general exertion. We want to use the gait belt and not patient's clothing or their arm. And we have to always be ready for a loss of balance, dizziness, fatigue, and be prepared at all times for the unexpected. Of course, we want to typically be on the involved side of the patient. So if they have a right knee surgery, a right ankle surgery, a stroke that affects the right side, we are going to be standing on the right side, slightly behind the patient, and that palm-up grip on the gait belt. Never leave a patient alone while standing or walking. We're going to have 2 labs to discuss all of this. On Monday, we're going to go through all the basics, how to fit an assistive device and which gait pattern to choose, and then how to teach a patient how to do all of this. The following Monday, on February 8th, we will practice gait with stairs, up and down curbs, and with IVs, like an IV pole and or portable oxygen. So one thing that sometimes is very helpful if your facility has parallel bars, which we'll show you a picture of those in a few minutes. This is a great way to do pre-gait activities. It helps the therapist to understand the patient's abilities. It's a very safe environment because the patient can hold on to very stable handholds on the parallel bars. And there we can practice moving sit to stand and stand to sit. We can work on weight shifts, balance activities. Maybe this is a great place to reinforce the weight-bearing status and make sure they're understanding that and able to maintain that weight-bearing status. We can do arm strengthening, of course, lower extremity strengthening with the sit-to-stand reps. They can also do marching. We can also get them in a gait position. So, for example, left foot forward, right foot back, and then do weight shifts forward to the left, back onto the right, and so forth. And also, for some patients, practicing the gait pattern in the parallel bars is a great preliminary step before they are walking just with the assistive device. We can use the gait belt and stand right next to the patient within the parallel bars to guard them. So in general, when we think about assistive devices, they are not inherently stable. Obviously, there are differences and between the various assistive devices, and we'll discuss that in this lecture. But we need to make sure that the assistive device is adjusted correctly, that it is in proper working order, um, and we need to be aware, of course, of loose clothing, uh, our own body mechanics, and our own safety as we are guarding and assisting patients. So, of course, the gait belt. In your textbook, there are some descriptions, and as we always say, reading the associated chapter in the textbook can help to fill in a lot of the gaps and answer a lot of questions you may have. Um, but as we said, in general, we're going to be on the involved side. If a patient has a postoperative uh, limb, that is the painful and weaker limb. And so if they were to lose their balance, if we had to guess, we would assume they would likely fall to that involved side. So that's where we will position ourselves. And we talked about being slightly behind the patient. Remember the importance of being able to uh, assess your patient visually. So you want to be able to see their face or at least maintain a dialogue with them to be sure that they are tolerating the gait activities appropriately. Um, and we've already talked through the types of assistance for transfers. Same is true with gait. When we're documenting, we would document the patient's independent with gait, and modified independence is often defined as the need for an assistive device and or any kind of involvement of the therapist. And then, of course, supervision versus contact guard. Neither of those levels of assistance provide any real physical help, but supervision means that the therapist is not comfortable with the patient being out of his or her sight, uh, but they can be away from the therapist with a gait or a transfer. Contact guard means that we need to be next to them with a hand on them. We're not necessarily providing physical help, but that comfort level of the therapist is not quite there to have them perform a transfer or ambulate with no contact at all. And then, of course, min assist, and mod assist and max assist, we've covered that. We can also have max assist of 2, or if there are 2 people involved. Um, so the general purpose of assistive devices is to increase that base of support for a patient. So if we are standing, if our patient's standing with the feet at shoulder width apart, we could draw a rectangle around the 2 feet, and that rectangle would be the base of support. Adding, for example, a pickup walker, now you've just increased that rectangle of support dramatically. A walker basically provides the most increase in base of support and therefore increases stability the most. And then you compare, for example, a front-wheeled walker to a single point cane, and a single point cane, if it's in the right hand of the patient, now that rectangle includes around both feet and the single point cane, and so it increases that base of support, but obviously not as much as a walker. So many different indications for the need for an assistive device. There's all sorts of musculoskeletal type of situations as listed here. Also, there may be some neuromuscular considerations, and then, of course, incorporating both of those would be balance. And so many different reasons why an assistive device might be indicated for our patients. So as we're considering an assistive device, we want to be able to protect our patient or our patient's limb after a surgery. And obviously, if someone's going to be non-weight bearing, they're going to have an assistive device that it uses both hands. You can't use a single point cane or a single axillary crutch safely and maintain non-weight bearing. So as soon as somebody's non-weight bearing, they're going to need a two-handed, if you will, upper assistive device to provide that stability. Um, Obviously, there are a lot of differences in patients and their needs, and we'll choose an assistive device accordingly.